Hello, welcome to Chess Lessons. Today I am going to present to you an overview of obstructive sleep apnea. What's the burden of obstructive sleep apnea? About 5% of middle-aged men and 2% of middle-aged women have OSA. More than 80% of people with OSA are not being diagnosed, and it may be even more in certain regions. Older people are more at risk, so 15 to 20% of those aged 70 and over are estimated to have this condition. People with OSA may have a life expectancy of 20 years, less than that of general public. Are we diagnosing all cases of OSA in the community? To diagnose it, we'll have to suspect every individual having risk factors for OSA. What is OSA? OSA is due to obstruction of the pharyngeal airway during sleep, resulting in transient apnea or hypopnea. This occurs many times during a night's sleep, causing frequent awakening. This leads to sleep fragmentation and nocturnal hypoxemia. OSA presents as loud snoring, nocturnal awakening due to choking sensation, abnormal limb movements, irregular breathing at night, nocturia, early morning headache and fatigability, excessive daytime sleepiness, and personality changes. What is happening during sleep? In these individuals, the upper airway relaxes, leading to loud snoring, and the airway closes partially or completely. Then the breathing stops. The oxygen level in the blood drops. The brain makes an attempt to wake up the patient. The patient gets woke up during the sleep. This is being repeated many times in a night's sleep. So when to suspect this condition? This should be suspected in obese individuals who complains of apneas or choking noises while sleeping. There is excessive daytime sleepiness. There is snoring or impaired concentration. Early morning headache is a frequent symptom. Fatigability, uncontrolled hypertension, and history of involvement in road traffic accidents. The individual has got a large neck size, like more than 17 inches in males and 16 inches in females. Increased waist circumference, large tonsil, especially in children, large tongue, abnormal craniofacial features, hypothyroidism. The individual is having mood swings, personality changes, or depression. If he is using more cigarettes, alcohol, or sedatives. Patient should be assessed. Rule out the causes for tiredness and fatigue. Asking about the effects of daytime sleepiness on driving and employment, relationship, mood, sleeping, and social life. Assessing the severity of sleepiness using an Epworth sleepiness score or a stop bank questionnaire. Asking the partner about the person's snoring habits, apneas, choking episodes. Look for comorbidities like uncontrolled hypertension, diabetes mellitus, and hypothyroidism. This is the chart showing Epworth sleepiness scale where certain situations are identified having chances of dosing in an individual and scores are given, and if the score is calculated to be more than 10, it appears to be a sign of increased daytime sleepiness. Further assessment can be done by nocturnal pulse oximetry to assess hypoxemia, arranging investigation for an underlying cause like obesity, hypothyroidism. Polysomnography either can be done full night or split night, and imaging for craniofacial abnormalities. Based on apnea hypopnea index calculated during polysomnography, individuals can be divided into normal if the AHI is below 5, mild OSA if it is between 5 and 50, moderate OSA if it is between 15 and 30, and severe OSA if it is more than 30. Certain individuals having work at risk areas or hazardous occupations should be referred for further evaluation. Patients with signs of respiratory and heart failure should be worked up for that, and patients having coexistent diseases such as COPD need further evaluation. Meanwhile, what we can do is advising on weight loss, exercise, smoking cessation, and reducing alcohol intake. Advising the person to try sleeping on the side, assessing, treating cardiovascular disease, hypertension, diabetes. Giving advice on driving, for example, not driving is sleepy, informing the authorities about the condition, checking entitlement to drive. Management based on the severity of OSA. What is mild OSA? Lifestyle modification is advised in the form of weight reduction, diet restriction, regular exercises. If moderate and severe OSA, regular CPAP during sleep is advised. If the patient is not tolerating CPAP or fail with CPAP, other options can be sought like mandibular repositioning devices or surgery. Thank you.